The triage framework, medical versus surgical. The most critical skill on the exam is deciding whether a horse needs fluids and time, or an immediate referral for surgery. 1. The standard workup. Exam questions often walk you through a case sequentially. Here is exactly what the findings mean. Heart rate, the pain indicator. Normal is 28 to 44 BPM. Greater than 60 BPM is concerning. Greater than 80 BPM is almost always a surgical lesion. Nasogastric NG intubation. Never skip this step on an exam. Horses cannot vomit. If you pull off greater than 2 liters of net reflux, it points to a small intestinal lesion, or duodenitis proximal jejunitis, DPJ. Abdominocentesis, belly tap. Medical, normal, clear to pale yellow. Total protein less than 2.5 grams per deciliter. WBC less than 5,000. Surgical, abnormal. Serosanguinous, red/tinged, fluid with high lactate. This means red blood cells are leaking through ischemic, dying bowel. Rectal palpation, displaced organs, tight bands crossing horizontally, or distended loops of small intestine indicate a surgical emergency. The high-yield anatomical danger zones. The horse's GI tract has specific choke points where things predictably go wrong. The pelvic flexure. The left ventral colon narrows drastically and makes a 180-degree turn to become the left dorsal colon. This is the absolute most common site for impactions. The ileocecal junction, where the small intestine enters the cecum, a prime target for tapeworms, Anoplocephala perfoliata, and intussusceptions. The nephrosplenic space, a natural shelf on the left side between the spleen and the left kidney, where the left large colon can get hooked, left dorsal displacement. The epiploic foramen, a natural opening in the abdomen where the small intestine can slip through and become entrapped and strangulated. Classic adult presentations. If you see these signalments on the BCSE, the diagnosis is practically handed to you. Pelvic flexure impaction. Any horse, often after a weather change or decreased water intake. Mild to moderate pain. Doughy mass palpable on rectal. Treatment. Medical. Fluids, laxatives. Strangulating lipoma. Older horse, greater than 15 years old. Severe, unrelenting pain. Distended small intestine on rectal. Serosanguinous tap. Treatment. Immediate surgery. Large colon volvulus. Broodmare recently post-foaling. Extremely severe pain. Rapid cardiovascular collapse. Toxic line on gums. Treatment. Immediate surgery. Nephrosplenic entrapment. Large breed horses. Warm bloods. Spleen is displaced medially on rectal. Treatment. Medical first. Phenylephrine to shrink the spleen, then jogging the horse. Duodenitis proximal jejunitis, DPJ. Moderate pain, fever, leukocytosis, and copious orange-brown foul-smelling reflux. Board trap. The heart rate decreases significantly after passing the NG tube. This differentiates DPJ from a surgical small intestinal obstruction, where the heart rate will stay high even after decompression. Regional, management, and toxic colics. The boards love testing geographic specificities and management practices. Sand colic. Horses housed in sandy areas. California, Florida. Diagnosed by listening for ocean waves on ventral abdominal auscultation, or by floating feces in a rectal sleeve with water to see if sand settles. Treatment. Enteral cilium. Enteroliths. The classic board signalment is an Arabian horse in California fed a diet rich in alfalfa hay. They form magnesium ammonium phosphate stones that usually lodge in the small colon. Right dorsal colitis, colic accompanied by hypoproteinemia, specifically hypoalbuminemia, and ventral edema. This is the classic presentation for NSAID toxicity, chronic phenylbutazone or flunixin meglumine. Thromboembolic colic, caused by Strongylus vulgaris larvae, migrating through the cranial mesenteric artery, cutting off blood supply and causing bowel infarction. Ascarid impaction, a weanling or yearling foal recently given a dewormer. A massive die-off of Parascaris equorum physically blocks the lumen. Cantharidin toxicity, blister beetles, associated with crimped alfalfa hay, causes severe colic, renal damage, hematuria, and oral ulcers. Board trap. Look for simultaneous hypocalcemia and hypomagnesemia on the blood chemistry. The pharmacology traps. You need to know the specific quirks of the drugs used in a colic workup, as the exam tests your ability to interpret clinical signs after a drug has been administered. Flunixin meglumine, Banamine, an excellent visceral analgesic, but it is so effective that it can completely mask the cardiovascular signs of a horse that desperately needs surgery until it is too late. Buscopan, N-butylscopolamonium bromide, an antispasmodic used to relax the rectum for safe palpation. Board trap. It causes a transient but severe tachycardia, often spiking to 80 to 90 BPM for about 30 minutes. You must check the baseline heart rate before giving it, or you will artificially create a surgical-looking heart rate. Alpha-2 agonists, xylazine, ditamidine, used for sedation and pain control. Xylazine provides about 20 to 30 minutes of analgesia. Ditamidine lasts longer. Both will decrease GI motility, which is an important consideration when auscultating gut sounds post-administration. Neonatal and foal emergencies. Foals are not just small horses. Their abdominal emergencies are distinct. Meconium impaction, the most common cause of colic in a newborn foal within the first 24 to 48 hours of life. They will strain to defecate and constantly flag their tails. Treatment: soapy water or acetylcysteine enemas. Lethal white syndrome occurs when breeding 2 overo paint horses. The foal is born all white and lacks intestinal ganglion cells. Ileocolonic aganglionosis. This means there is zero GI motility, and it is uniformly fatal. Ruptured bladder. While not a true GI colic, it looks exactly like one. A 2 to 3 day old colt, usually males due to a longer, narrower urethra, will be straining to urinate. Board trap. The classic serum biochemistry profile will show hyponatremia, hypochloremia, and hyperkalemia.